Today we have the great pleasure to host Matthias Pinter, who works in Vienna at the Division of Gastroenterology and Hepatology, Department of Medicine, the third department, at the University of Vienna. Matthias has a long history of expertise in hepatology, and particularly in the recent time on the immunotherapy. And what Matthias agreed to address for us today is to move from what is really academic to the real scenario with the clinical one. Therefore, his title is Immunotherapy for Hepatocellular Carcinoma, Challenges in Clinical Practice. Matthias, the mic is yours, and we are looking forward to your seminar. Thank you very much.
Yeah, thank you very much for this nice introduction, and also for inviting me to give this presentation today. Okay, so this is just the agenda for today. I will start with a short introduction and will then dive into some clinical scenarios that we often face in clinical practice, but where we do not have high-level evidence from phase 3 trials. And that includes patients with impaired liver function, Child-Pugh class B patients. That also includes treatment sequencing after first-line IO treatment, as all the treatments that we have for HCC have been tested in treatment-naive or sorafenib-experienced patients. Then I will also talk about the underlying liver disease etiology, as there has been some debates and discussions over the last couple of years following a Nature publication suggesting that immunotherapy may not work well in NASH or MASH patients, how we call it these days. And finally, I want to talk about the peri-transplant setting, where we basically have two scenarios. We can use immunotherapy prior to liver transplantation as a downstaging or bridging therapy, or a systemic therapy can be used to treat recurrent HCC after liver transplantation. So basically the post-transplant setting. Now, liver cancer, as you all know, is one of the most common cancers globally. It ranks 6th place in terms of incidence and 3rd place in terms of mortality. In men, it is even 2nd place in terms of mortality. And most of these liver cancer cases are hepatocellular carcinomas. The BCLC algorithm, I'm sure those of you who treat HCC patients regularly know this algorithm. It has been endorsed by many guidelines and has just been updated recently last year and published in the Journal of Hepatology. And according to this algorithm, we can differentiate between 5 tumor stages based on a tumor burden, liver function, and performance status or physical status of the patient. And this algorithm basically allocates evidence-based treatment strategies to each of the resulting tumor stage. And for early stage patients, as you know, we have potential curative therapies like ablation, resection, or liver transplantation. For patients with intermediate stage HCC, where the tumor is still limited to the liver, we can do TACE if the nodules are well defined and the liver function is preserved. However, in those with diffuse infiltrative type of HCC, or in patients with advanced stages where we have already a vascular invasion or extrahepatic metastasis, systemic therapy is the treatment of choice. And that is the field where we have seen the most advancements over the last couple of years, including the addition of immunotherapy to the treatment armamentarium of HCC patients. Now, for the longest time, we have been using targeted therapies in HCC. And with these kind of treatment, we have usually seen an early treatment benefit because these agents can delay tumor progression. Sometimes they induce responses. But the number of patients with long-term response and long-term survival are rarely seen with targeted therapies. With immunotherapy, the goal is really to increase the tail of the survival curve. In other words, we want to produce a high number of long-term responders and long-term survivors with this kind of treatment. Now, like in many other tumors, it all started with PD-1 targeted monotherapies. We have seen encouraging data from phase 2 trials in HCC, but the subsequent phase 3 trials, which you can see here in this slide, the Checkmate 459, which tested nivolumab versus sorafenib, and the Keynote 240, which tested pembrolizumab versus placebo in sorafenib experienced patients, both failed to improve their primary survival endpoints, were negative, and therefore it became clear quite early that in HCC we probably will need combination therapies in order to make immunotherapy work better in these patients. The first combination therapy that actually was approved in Europe and the United States as well was the combination of atezolizumab plus bevacizumab, which was tested in the IMbrave 150 study versus sorafenib, the prior reference standard. And the combination treatment actually improved both primary endpoints, progression-free survival and overall survival, and the median survival of 19.2 months was the longest survival ever recorded for first-line treatment back then. And particularly those patients with a response to treatment had the best outcomes. Patients with stable diseases, best radiological response also benefited from immunotherapy. The second regimen that was approved for HCC in Europe was tremelimumab plus durvalumab according to the STRIDE regimen, which means single dose of tremelimumab followed by regular interval durvalumab every 4 weeks. The Himalaya trial also had a durvalumab monotherapy arm, and both were compared to sorafenib. And while durvalumab monotherapy showed non-inferiority in terms of overall survival, the primary endpoint of this trial, the STRIDE regimen significantly improved overall survival and became later on approved for HCC by the European agencies. This is the 4-year updated OS data according to response, which were presented earlier this year at ESMO GI. And what they show here is overall survival by disease control, which means patients with stabilization or a response. And after 3 years, almost 50% of the patients were still alive. And at 4 years, 1/3 of all patients were alive. And that is quite remarkable and unprecedented for such advanced tumors. Now, the AASLD guidelines, which were published just earlier this year, therefore recommend to use either atezolizumab plus bevacizumab or tremelimumab plus durvalumab as a first-line treatment, only in patients with a contraindication for immunotherapy. We should use TKIs, and they recommend the prior first-line TKI sorafenib or lenvatinib as first-line treatment. Then we have regorafenib, cabozantinib, and ramucirumab as further options. And in the United States, nivolumab and ipilimumab or pembrolizumab, which have been conditionally approved there, but we don't have them in Europe. That is what changed over the time with advancements here in the systemic treatment landscape. This is the pre-sorafenib era where we didn't have any systemic treatment options available for these advanced tumors. Median survival back then was around 8 months with TKIs and monotherapy. We could prolong median survival to more than 12 months. With TKI sequencing, we could achieve a median survival of 2.5 years in selected patients with preserved liver function. And with atezolizumab and bevacizumab or tremelimumab or durvalumab, we can achieve around 16 to 19 months in median survival. And we can expect even longer survival rates with treatment sequencing here. But these data are not available yet. And data for new therapies and triple combinations are also not available. And we will see them probably within the next couple of years. And that is probably how the future of first-line treatment may look like. Triple combination therapies. These data from the Morpheus liver phase 1b/2 study were published, were presented at ASCO this year, comparing the triple combination of tiragolumab, which is a TIGIT inhibitor, in combination with atezolizumab plus bevacizumab versus atezolizumab and bevacizumab. And they showed a tripling in response rate and a significantly improved progression-free survival rate. Even though it was small patient numbers, the results were quite encouraging. Safety profile was acceptable, and therefore the company decided to launch a phase 3 trial testing this triple combination versus atezolizumab plus bevacizumab in the first-line setting. Now, let's start with some clinical scenarios that we often face in clinical practice, but where we do not have any clear guidance because high-level evidence is missing. And the first subgroup of patients I want to discuss today is the group of patients with Child-Pugh class B. As you know, these patients are usually excluded from clinical trials because they often die from complications of liver cirrhosis, and death from such a complication could mask a potential anti-tumor effect of a drug. Therefore, the guidelines usually only recommend systemic therapy for Child-Pugh A patients, but not for Child-Pugh B or C patients. What we have in Child-Pugh B patients is data from mainly retrospective, small retrospective studies, or prospective observational registry trials like this one here, the Gideon study, which tested sorafenib in real-world clinical practice, a large study with over 2,000 patients. And the study showed what many other retrospective studies have shown before, namely that Child-Pugh A patients have a significantly longer survival than Child-Pugh B or C patients. And even within the Child-Pugh B population, which is a very heterogeneous group, which can range from a compensated B7 to decompensated B9 patients, that with each increase in the Child-Pugh score, the survival drops further. And we have also similar data for immunotherapy-treated HCC patients. These are summarized here in this table. Only one prospective trial, which I will discuss later, and some retrospective studies, small retrospective studies, the largest one from Asia here, testing atezolizumab and bevacizumab and comparing the outcome between Child-Pugh A and B patients. And what they found is basically that response rates were quite similar here. And the safety profile between Child-Pugh A and B patients was also quite comparable. But their survival is inherently shorter, and that is mainly because they often die from complications of liver cirrhosis. And that is the study by D'Alessio here, showing that the median survival was 16.8 for Child-Pugh A patients, so quite similar to the IMbrave 150, a phase 3 trial, but Child-Pugh B patients have only a median survival of 6.7 months. However, response rates were quite comparable, as was the safety between Child-Pugh A and B patients. And this is a meta-analysis that was also published earlier this year, confirming a median survival of Child-Pugh B patients treated with immunotherapy of around 6 months. And that is, and these Child-Pugh B patients have an increased risk of death when compared to Child-Pugh A patients. Nothing new, but confirmed in a large meta-analysis. And that is another meta-analysis also published earlier this year in JAMA Oncology, confirming the lower survival. And what they also demonstrate is a lower response rate, but a similar rate of adverse events between Child-Pugh B and A patients. So there seems not to be a safety concern, but efficacy may be lower in Child-Pugh B patients. This is the only prospective cohort that I'm aware of. That is the cohort 5 of the CheckMate 040 study, which tested nivolumab in sorafenib experienced or sorafenib naive patients. This cohort included 49 patients with Child-Pugh B7 or 8. Half of them were sorafenib naive, half of them sorafenib experienced. And they reported an overall response rate of 12% and a disease control rate of 55%. Safety was comparable to that of Child-Pugh A patients. And what is important and why I'm showing this is because what they reported is an improvement to Child-Pugh A from Child-Pugh B, which lasted for at least 6 months in 5 patients. So in 10% of the patients, and most of these patients had a partial response. So basically, some of these patients, actually those who showed a response to treatment, also demonstrated an improvement in liver function. And therefore, that is just our approach that has not been confirmed in prospective trials yet, but that's how we approach Child-Pugh B patients. So we do not exclude them from systemic therapies, but what we try to look at is what the main cause of liver function impairment is. Is it either a large tumor in a patient with no or mild cirrhosis? We often see NASH patients with no cirrhosis, but large tumors at the time of diagnosis. Or is it a low tumor burden, but severe cirrhosis, severe portal hypertension, where cirrhosis and portal hypertension and its complications are the main life-limiting condition and not the tumor itself? So if the answer is the first one, we have a high tumor, but otherwise no or mild cirrhosis, we consider systemic therapy, but in patients with small tumors and severe cirrhosis, we do not treat these patients with systemic therapies because even if they respond to treatment, they may not derive a clinical benefit from this treatment. And then there are some other factors along the way that we consider when we make these decisions. Now, the second topic I want to discuss here today is treatment sequencing after first-line IO treatment. As you all know, and as I've just mentioned, all the drugs that have been approved for HCC so far have been tested in treatment-naive patients or in sorafenib-experienced patients, but we don't have any phase 3 trials testing treatment sequencing after first-line IO treatment. Now, the first question that we have to ask when we talk about treatment sequencing is how many patients actually qualify for a second-line treatment. And when we look at data from phase 3 trials testing immune checkpoint inhibitors in first line, this number was around 40 to 50%. So around about half of the patients actually qualify for a second-line treatment in clinical trials. And when we consider these patients are the best of the best, those with a good liver function and a good performance status, we can imagine that in real life, where patients are usually sicker, this number is even lower. And I would assume that around 1/3 of all patients receiving first-line IO treatment will qualify for a second-line treatment. So data from prospective trials after first-line IO treatment are lacking, and therefore we only have to and only can rely actually on small retrospective studies investigating treatment sequencing after first-line IO treatment, like this one here published in Liver Cancer, where patients received sorafenib or lenvatinib and one patient cabozantinib after first-line atezolizumab and bevacizumab. And what they reported is a median survival of 14.7 months, which is what you would expect in these patients if receiving these TKIs in first line as well. So efficacy seems not to be hampered by a first-line IO treatment. That is what we expected anyway. And safety was also not an issue. And this is a larger study published earlier this year, including 130 patients that received atezolizumab and bevacizumab in first line and were then treated with mainly lenvatinib or other TKIs or ramucirumab. And they also reported a median survival of around 1 year and found no difference between lenvatinib treated patients and those who received other treatments than lenvatinib in second line. This Markov model also investigated the efficacy and safety of different sequencing strategies after first-line atezolizumab and bevacizumab. And what they found is that the sequence atezolizumab plus bevacizumab followed by lenvatinib or sorafenib were the most effective treatments. And the sequence atezolizumab plus bevacizumab followed by sorafenib was the safest strategy. So based on this Markov model, they suggest that the prior first-line TKIs, lenvatinib or sorafenib, should be used as preferred second-line treatments after atezolizumab and bevacizumab. This is prospective data actually from the REACH trial. That was the expansion cohort, including 47 patients that received other treatments than sorafenib as a pre-treatment before receiving ramucirumab as a second-line treatment. The majority of the patients, actually 2/3 of the patients, received immune checkpoint blockers as a prior treatment. And when you look at the median survival, which was 8.7 in this study, it was quite similar when compared to the overall cohort of the REACH2 trial that received sorafenib as a first-line treatment. So again, the first-line treatment seems not to have any impact on the efficacy of TKIs or ramucirumab, at least what retrospective data tell us. Now, since we have 2 IO combinations available now in Europe as potential treatment options for HCC patients, IO rechallenge, which is the use of immunotherapy after prior immune checkpoint blockage, becomes an option that we have and that we can apply in clinical practice. Both agents IO combinations basically use an anti-PD-1 or anti-PD-L1 targeted immunotherapy as a backbone, so to say, which basically enhances T-cell response against cancer cells. And when we combine these PD-L1 target monotherapies with bevacizumab, for example, anti-VEGF treatment, we also have a reprogramming of the immunosuppressive tumor microenvironment, because VEGF is not only an angiogenic factor, but it also has immunosuppressive effects in the tumor microenvironment. So basically, we reprogram the immunosuppressive microenvironment with anti-VEGF treatment. And on the other hand, when we combine anti-PD-L1 targeted monotherapies with a anti-CTLA-4 antibody, we have a different mechanism of action, because these agents mainly lead to T-cell priming in the lymph nodes. So we have different mechanisms of action of the two IO combinations, and that at least provides a theoretical rationale why IO rechallenge might be an alternative option besides TKIs as a second-line treatment after first-line IO treatment. And we also have only data from retrospective studies on this topic. This one is a study from Asia, including 25 patients who received ipilimumab plus nivolumab or pembrolizumab in ICI refractory HCC patients. Most of them received immune checkpoint inhibitor monotherapy in first line. Only one had atezolizumab and bevacizumab as a pretreatment, and they reported a response rate of 16% and a median survival of 16.2 months in Child-Pugh patients, which is quite remarkable for a second-line treatment, but again, a small patient number. And this is a similar study that was published earlier this year, based in the United States, where ipilimumab was compared was combined with nivolumab in immune checkpoint inhibitor refractory HCC patients. It was 32 patients that were actually included in this trial. Most of them received a combination therapy in first line, mainly atezolizumab plus bevacizumab, or other ICO combinations with VEGF inhibitors. Only 6 patients received ICI monotherapy, and what they reported is an overall response rate of 22%. One patient actually achieved a complete response, and it was very interesting because they reported that all patients who responded to the second combination therapy with ipilimumab and nivolumab all had progressive disease at the first radiological evaluation during the prior ICI line. So they all had primary resistance to the first IO regimen, but responded to a second one, suggesting that even in those who do not respond to a first IO regimen, a different combination may induce responses even in these refractory patients. This is a study that we published last year, probably the largest study, at least that I'm aware of, on this topic of immune checkpoint inhibitor rechallenge in HCC patients. And what we did is we screened almost 1,000 patients from 14 centers, and have identified 58 patients who received at least 2 lines of immunotherapy. Most patients received either immune checkpoint inhibitors alone with the first IO regimen, or a combination treatment. And with the second IO line, most patients received combination therapies. Only 4 patients had immune checkpoint inhibitor monotherapies. And what we found is that the response rate to the first IO line and second IO line was quite similar, with a response rate of 22 and 26%, as was the disease control rate and the median time to progression. And the safety was also quite comparable. And again, we also had some patients that responded to the second IO regimen, but had primary resistance to the first IO regimen. So overall, these data, even though retrospective data, suggest that even in those who do not respond to the first IO line, a second IO regimen with a different combination may induce responses and could give the patient another chance of becoming one of these long-term responders that we often see with immune checkpoint blockers. So that is a treatment algorithm that we just proposed recently in the Lancet Gastroenterology and Hepatology, where we propose both options, either IO rechallenge or a TKI after first-line IO treatment. TKIs are certainly the preferred option in patients who did not tolerate the first IO regimen well. And the AASLD practice guidelines also recommend primarily one of the previous first-line TKIs in second-line after first-line IO treatment, but they also consider IO rechallenge here as an alternative in selected patients. Now, the next topic I want to discuss is the underlying liver disease etiology as a prognostic factor in patients undergoing immunotherapy. This paper, published by the Heichenwälder group in Nature 2 years ago, started actually this debate on whether NASH may hamper the efficacy of immunotherapy. Because what they demonstrated is in a meta-analysis of the phase 3 trials that were published back then, which was the Checkmate 459, the Iron Brave, and the Keynote 240, that immunotherapy worked well in viral HCC patients, but not so much in non-viral HCC patients. So compared to the control arm, there was no significant improvement for immunotherapy-treated patients. And similar data were seen in 2 independent retrospective cohorts where patients with NAFLD or MASLD, how we call it these days, had a shorter survival than patients who had other underlying liver disease etiologies. And in preclinical high-fat diet mouse models, they found that PD-1 positive, CD8 positive autoaggressive T cells expanded when treated with anti-PD-1 targeted monotherapy. And these autoaggressive T cells led to increase in liver damage, and they also increased hepatocarcinogenesis. Here we have a higher tumor incidence in anti-PD-1 treated mice compared to the control mice. And when these CD8 positive T cells were depleted, the tumor promoting effects of anti-PD-1 targeted monotherapy were reversed. A similar study that was published last year also reported that immune checkpoint inhibitors worked in normal diet mice with HCC, but not in high-fat diet mice. So there was no difference. Anti-PD-1 treatment did not have any anti-tumor effects. But when these high-fat diet HCC mice were treated with metformin and anti-PD-1 treatment, they observed anti-tumor effects. And in further analysis, they found out that it seems that metformin can rescue and restore T cell metabolic functions and motility, and proposed that metabolic reprogramming may improve the efficacy of immunotherapy in MASH-related HCC. But of course, that has not been confirmed in clinical trials yet. This is an updated meta-analysis of phase 3 trials. Basically all phase 3 trials testing immunotherapy in advanced stage HCC that have been published so far. And it was published earlier this year in the Journal of Hepatology. And what they found, in contrast to the meta-analysis that was included in the Nature paper, that immunotherapy versus control arm worked in all 3 subgroups, in hepatitis B, hepatitis C, and non-viral related HCC patients. This study here, study from Italy, actually published in ESMO Open last year, also compared atezolizumab plus bevacizumab versus lenvatinib in patients with MASLD and non-MASLD HCC. And what they found is that in the MASLD population, lenvatinib showed an improvement in overall survival versus atezolizumab and bevacizumab, which was significant, but that was not the case in the non-MASLD HCC population. However, when you look at the median survival of atezolizumab and bevacizumab treated patient, it was just 12 months here, as well as 11.6 months here. So quite similar in both subgroups. And when compared to the Iron Brave 150, the median survival of 12 is way shorter than what we would expect from this treatment in patients with HCC and preserved liver function. So this study certainly also has its limitations, as all retrospective studies do have, and therefore, and to basically summarize the data that we have just seen, there is some evidence from preclinical trials and retrospective studies suggesting that immunotherapy may be less effective in NASH patients. However, this data is low-level evidence, as we only have preclinical data and retrospective analysis demonstrating that, and therefore I would not withhold immunotherapy from MASLD or MASH patients. At this point, we can only consider this data hypothesis generating, but I would not base my clinical decisions on that. Now, the last topic I want to discuss is the peri-transplant setting. So we have basically two scenarios. We have the pre-transplant setting, where immunotherapy is used to downstage or bridge HCC patients before liver transplantation. And we have the post-transplant setting, where systemic therapy is used to treat recurrent HCC after liver transplantation. Now, the first topic, the pre-transplant setting, I want to start off with a case report that was published this year from colleagues from Innsbruck in Austria, who had a HCV-related multifocal HCC patient with a large HCC nodule of 11 centimeters with a vascular invasion. So clearly outside of any transplant criteria, and clearly a candidate for systemic therapy. And what they did is they started atezolizumab and bevacizumab, but observed an outstanding response, especially this large 11 centimeter tumor with vascular invasion that you can see here in this image disappeared completely. And the patient was radiologically within the Milan criteria. Only 5 out of 8 lesions had no contrast uptake anymore. So there were only 3 lesions left that were all below 3 centimeters, and the patient was within Milan, at least radiologically. So they started to discuss this patient in the transplant board, and finally decided to list the patient for liver transplantation. He finally got transplanted 6 weeks after the last atezolizumab cycle, so basically a washout period of 6 weeks, and 8 months after atezolizumab and bevacizumab was initiated. And on explant histology, the patient had still 5 small vital tumor lesions with up to 1.3 centimeters. So pathologically, he was outside of the Milan criteria, but interestingly, this large tumor that disappeared on imaging also had a complete response on explant histology, and the vascular invasion also completely responded to atezolizumab and bevacizumab. The patient did not show any signs of graft rejection, and he was without recurrence within the first 12 months after liver transplantation. Here is the tumor marker, AFP, dropped from over 60,000 to normal values and remained down there during the observation period. So that case demonstrates that with immunotherapy, we really have, and we can often see deep and durable responses that can even lead to a stage migration from the right to the left. So even patients that are way outside of Milan could potentially become candidates for liver transplantation once they show these outstanding responses. And therefore, this topic, the topic of immunotherapy in the peri-transplant setting, will become a topic that is more and more timely, with more and more effective treatments coming and being added to the treatment algorithm of HCC in the near future. This is a case series of 5 patients that received nivolumab prior to liver transplantation. And what they reported is actually of these 5 patients, 2 patients showed a biopsy-proven acute rejection. One patient even needed graft rejection. So there is certainly a risk of graft rejection. This is another one from Asia, where patients received PD-1 targeted monotherapy in combination with lenvatinib. 7 patients, one of them had a graft rejection, but did not require retransplantation. And this is a series from the United States, 9 patients. They also received nivolumab before liver transplantation. Some of them even received the last dose of nivolumab 7, 2, or even 1 day prior to liver transplantation. So there was no washout period, and only 1 patient experienced a mild rejection without requiring retransplantation, but all the other patients, even those who received the last dose of nivolumab quite before liver transplantation, did not show any signs of graft rejection. Now, what do the guidelines say? How should we approach this topic, immunotherapy prior to liver transplantation? This is a statement from the European Society of Organ Transplantation. Well, they recommend they conclude that no recommendation can be made because there is insufficient evidence. There are only these few case series and case reports that I've just shown you, and they suggest that further investigations should focus on the safety and long-term oncological outcomes, and they also highlight the unmet need if we need a minimal washout period between the last immunotherapy cycle and transplantation. But again, they cannot make any clear recommendations because the evidence is lacking. From what I've shown you is that there is a risk for rejection, but patients around the liver transplantation or right after liver transplantation receive high doses of immunosuppressive therapies. So some colleagues from my department, and we have discussed it extensively with them, do not think that the risk of graft rejection is very high because of these high doses of immunosuppressive therapies. It's rather in the maintaining phase of immunosuppressive drugs where you have an increased risk for graft rejection because the doses are quite low, as we will see in the upcoming slides. I have prepared some slides for the post-transplant setting as well. So that is basically the summary, a pooled analysis of 52 patients who received immune checkpoint inhibitors after liver transplantation. So the second scenario, where we have patients that have tumor recurrence, HCC recurrence after liver transplantation. They usually are already at a maintaining dose of immunosuppressive agents, a low dose of immunosuppressive agents, and therefore they potentially have a higher risk of developing graft rejection. And in this series of 52 patients, one of the largest series published to date in Liver International, they reported a rejection in almost 1/3 of all patients. Some of these rejections were even lethal. So certainly a concern, and even a greater concern than in the pre-transplant setting. But the overall response rate was 35%, so quite similar to patients who are not under immunosuppressive therapy. So it seems that this low-dose immunosuppressive treatment does not hamper the efficacy of immunotherapy. But overall, significant and substantial risk of graft rejection that we have to be aware of. And therefore, I would not recommend to use immunotherapy as a first-line treatment to treat recurrent HCC after liver transplantation, because we have data, even though retrospective data, for TKIs, the first-line TKIs, sorafenib and lenvatinib, demonstrating survival rates that were quite similar to those in non-transplant patients, even longer, because they have excellent liver function, and we all know that liver function is one of the most important prognostic factors in these patients. So good data for TKIs, good safety data and efficacy data, and that is also what the most guidelines recommend the EASL, the AASLD practice guidelines, as well as the BCLC update and EASL guidelines all recommend that liver transplantation, a history of liver transplantation should be considered a contraindication for immunotherapy, and therefore sorafenib or lenvatinib should be used as the preferred options in first line. There are some prospective trials ongoing testing immunotherapy in the peritransplant setting. Most of them evaluate immune checkpoint blockers for downstaging before liver transplantation, but there's also one study that is investigating immunotherapy in patients with recurrent HCC after liver transplantation, and specifically they look at the rate of acute graft rejections and severe adverse events. Now that is the last slide for today, my take-home message. So the Child-Pugh population is a very heterogeneous group of patients, ranging from compensated Child-Pugh 7 patients to decompensated Child-Pugh 9 patients. And we know, at least from retrospective data, that patients with Child-Pugh can also derive a clinical benefit from immunotherapy. We just do not know who these patients are. Maybe it's those with the large tumors and vascular invasion that can derive a clinical benefit once they respond to immunotherapy. Therefore, and that's how we approach these patients. If we believe that the tumor is responsible for liver function impairment, we consider patients for systemic therapy and immunotherapy. And if we believe that advanced cirrhosis and portal hypertension are the main drivers and the main life-limiting condition, then we do not consider systemic therapy. Sequencing after first-line IO treatment is purely empirical because we do not have data from phase 3 trials. So we can do either a TKI after first-line IO treatment, or we can consider IO rechallenge. Guidelines, most guidelines, including the AASLD guidelines and the BCLC update, as well as ESMO guidelines, prefer to use a TKI after first-line IO treatment. But again, that is also not backed by high-level evidence. The discussion about lower efficacy of immunotherapy in the MASLD population is basically only based on low-level evidence. We have data from preclinical studies, retrospective analysis, and meta-analysis of phase 3 trial subgroups that have their limitations, including that these subgroups are not balanced for other prognostic factors. They were heterogeneous in terms of treatment line and agent. Therefore, overall, these data can only be seen as hypothesis generating, and I would say that immunotherapy should not be withheld from patients with MASLD or MASH-related HCC until we have data from prospective trials confirming these retrospective and preclinical data. In the peritransplant setting, immunotherapy may be used prior to liver transplantation as a downstaging or bridging tool, but there is a risk for rejection. However, this risk seems not to be as high as for patients receiving immunotherapy in the post-transplant setting to treat HCC recurrence after liver transplantation. For these patients, I would prefer, as recommended by most guidelines, that TKIs should be used as the preferred option in first line. Thank you.
Well, thank you very much, Matthias. This has been an excellent presentation, very clear.